Nick. You had shared a case, patients having some issues. You had said number 2 was recently removed. This is the pre-op CAT scan taken. You most likely were trying to assess whether or not the roots were adjacent to the sinus. Quite often these roots are quote unquote in the sinus, but what's important to note is that in the sinus has 2 different boundaries. One is the cortical bone. That's often where the roots are adjacent to, and then you have the Schneiderian membrane. And OAC is when you have a hole or a communication through both, not necessarily just the bony aspect. So when we see root proximities to the sinus, that doesn't mean we're going to have an OAC. It just means we're at higher risk for it. And in reality, lots of teeth have that. So I always recommend anytime a posterior tooth is removed in the maxilla, that we just know how to repair them in the moment. And there's lots of ways to do that, but a topic for another day. So your patient is having pain in this area, a bad taste, and some swelling on the palate. So kind of a unique combination of symptoms. Let's take a look at the CAT scan that you had recently sent. So this is the post-op CT, and your thought was maybe there's an OAC where the patient's bad taste is coming from some bacteria within the sinus, and the swelling in the palate is coming from that OAC. So before we dive deeper into that, what I will say is OAC, confirming OACs has a high degree of false negatives. And that has to do with the fact that you might have, I wouldn't say a high degree, it has a chance for false negatives based on the fact that you can have mucus buildup in the sinus that will prevent airflow through the hole or through the communication. So when you get bubbling or you get airflow through, that's a positive outcome of the Valsalva maneuver. And the Valsalva maneuver, for those listening, is when you have the patient pinch their nose but try to blow through their nose, and that creates a positive pressure within the sinuses. And when they do that, if there's airflow, either a whistling sound or bubbling, we'll often see bubbling with any blood that's in the area, will confirm that there's an OAC. But as we just talked about, an OAC is when the Schneiderian membrane and the bone is perforated. And we're going to dive into that a little bit later. So Valsalva maneuver in and of itself is just another tool to diagnose, but it's not an absolute tool based on the fact that you can have mucus buildup or some sort of polyps covering that, preventing airflow from giving you the ability to diagnose an OAC. So when I see something like this right here, so let's take this pan over, and now we're looking at the frontal view here. That alone doesn't really tell me a whole lot. It tells me that the cortical bone is perforated, but it's very possible that the Schneiderian membrane is not perforated. So I'm not sure that that's necessarily contributory. You're about 2 to 3 weeks post-op, so I would imagine if this was an OAC that you would see the typical invagination of the mucosa. So if you've never seen an OAC that's quote-unquote healed, and when I say healed, the OAC is present, but the epithelium lining is contiguous from the Schneiderian membrane all the way to the palatal mucosa or keratinized gingiva. So when you see that, it's rather evident, and that's something that you definitely want to send to a surgeon that can repair those. When they're small, they're sometimes hard to see, but when they're there, they're there. But you're still in that middle ground period where it's possible that there's a pinhole communication so that you can't really see it. With that said, the location of the inflammation would give you a lot more information. But you were saying it was more on the palate. So we're looking up in this area here for some signs of issues. So a tentative diagnosis of an OAC causing palatal swelling, on the surface gives me a little bit of pause. So I want to explore a little bit more to try to get a sense of what might be going on. Now, what we did see is we saw a root that communicated or came in close proximity to number 1. So this being number 1. Let's go take a look over there to see what we can find. So if we come over like so, right here was I'm guessing that was the palatal root of number 3. Could have been the distal buccal and the tooth was rotated. Neither here nor there. It was a root that no longer exists, but you have that alveolus still present. And where it's so close, I want to take a look at number 1. And there we go. So number 1 has a palatal root that is, I'm going to use the word perforation, but a different kind of perforation. This root is perforated through the palatal bone. It's very possible that that's the infection that's giving the palatal swelling. I don't know why, but these typically hurt. I've had patients that have had similar scenarios where the swelling has concentrated itself on the palate. It might have to do with the greater palatine nerve, but it typically is something that they feel, and it presents maybe more profound than had the swelling been on the buccal. That's just an experiential observation. With that said, this really makes a lot of sense. When we look in the sinus here, this root does extend into the sinus, and we have some Schneiderian membrane reaction to what's going on. This might be some mucus buildup, but based on the fact that this image here, it looks dome-shaped around the apex of the tooth, I'd call this a sinus inflammation of odontogenic origin, just based on the fact that it's symmetrical around the apex of the tooth. Same with this guy right here, not surprising considering we have this right there. So to take a small step aside, I used to refer when I first got the CAT scan, I used to refer a lot of these quote unquote polyps to the ENT. And 99 times out of 100, they would send it back saying, why are you referring these to us? And I'd always say, can you please clarify on the ones that you want sent to you? And I'd get crickets. So only now do I have a pretty good understanding of when to refer to the ENT. Without a question, when you see complete opacification of the sinus, that's a good indication that the patient should be referred. But when you see these small polyps, those are pretty inconsequential. If anything, you should refer to your dentist, which is us. All right, back to this. So my thought is that this root was infected, or just the opening created the ability for bacteria to travel down into this little area right here, which reminds me, let's see if this was present on the other CAT scan. And it was not. So it's very possible that this communication was non-contributory until the tooth came out. Tooth came out, bacteria traveled in, and then set up shop in the PDL in an area where the anaerobes were probably likely to thrive. Because if we look at the post-op image, we definitely have some reaction there. So my thought is that this tooth should probably be seen by endo. Oral surgery, I don't think is going to look at this with the magnifying glass that we're looking at it. Perio might, but I think endo would be the most likely specialty to kind of dissect this and give the tooth the best chance for survival. The problem is this strikes me as an infection of periodontal origin. If we're surmising that the infection came from here and then set up shop, most likely the pulp will need to be treated also. But I would start with the endodontist if you decide to save this tooth, and then have them quarterback with the periodontist, which might make sense based on the fact that this is the only occlusal stop on this side. So hopefully this helps. I definitely don't think it's an OAC. Without a CAT scan, I don't know how we would have resolved this. Another good reason why CAT scans are, a very important part of the armamentarium of diagnosis and what we do. So please keep me posted, and I look forward to helping you further. Take care.